Hello, my name is Nicole Pilicki, and I am currently a fourth-year pharmacy student at Drake University. Today, I will be presenting to you a medication review on the drug Kerendia, also generically known as Finerenone. Finerenone, also known as Bay 948862, was discovered in 2012 by Bayer Pharmaceuticals. Between the timeline of 2012 to 2021, Finerenone was investigated in a multitude of clinical trials. And on July 9, 2021, the U.S. FDA approved Finerenone for use. Finerenone is a non-steroidal mineralocorticoid receptor antagonist. For simplicity, I will be referring to it as a non-steroidal MRA. There have been 2 phase 3 clinical studies completed with Finerenone in patients with diabetic kidney disease. Why in these specific patients? Some people with diabetes develop kidney and heart problems because their body is producing too much steroid hormone, causing excessive inflammation and damage. Over time, these excesses can lead to loss of organ function. MRAs can block this effect on the mineralocorticoid receptor and so reduce associated kidney and heart problems. The fidelity analysis from these 2 trials focusing on the effects of Finerenone has demonstrated efficacy in reducing major cardiac and kidney outcomes in patients with chronic kidney disease and type 2 diabetes. The approved FDA indication is to reduce the risk of sustained estimated glomerular filtration rate decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure in adult patients with chronic kidney disease associated with type 2 diabetes. In order for my listeners to have a better understanding of the mechanism of Finerenone, I would like to first discuss the background of the renin-angiotensin-aldosterone system, also termed RAS. Overactivation of the RAS has been shown to be pathologic in heart failure and chronic kidney disease by triggering inflammatory and fibrotic pathways. Aldosterone is a mineralocorticoid steroid hormone that plays a central role in the homeostatic regulation of blood pressure, plasma sodium, and potassium ion levels by activation via intracellular mineralocorticoid receptor, also known as MR. Elevated aldosterone release and high salt load increase hemodynamic, inflammatory, and fibrotic factors, driving MR overactivation. The standard of care in these disease states includes treatment with ACE and ARBs. Mineralocorticoid receptor antagonists are an adjunct therapy option for both disease states. However, therapy is often limited by treatment-related hyperkalemia. This hyperkalemia risk is what led to Finerenone, a non-steroidal MRA, being developed. The illustration depicted portrays how Finerenone blocks the harmful effects of MR overactivation by aldosterone and leads to beneficial outcomes. In the heart and vasculature, Finerenone has been shown to improve vasodilation and left ventricle perfusion to decrease fibrosis and inflammation. In the kidney, Finerenone substantially improves glomerular damage by reducing vasoconstriction, proteinuria, and fibrosis. Although Finerenone has a short half-life and a modest effect on blood pressure, it has very potent anti-fibrotic and anti-remodeling effects, which can slow chronic kidney disease progression and improve cardiovascular outcomes. As mentioned before, Finerenone is a non-steroidal MRA with high potency and selectivity for the mineralocorticoid receptor, also known as MR. The MR is a ligand-activated nuclear transcription factor that is expressed in many types of cells, including endothelial cells, vascular smooth muscle cells, and fibroblasts. In epithelial cells, the MR is activated solely by aldosterone. MR activation in renal epithelial cells leads sodium and fluid retention and potassium excretion. Finerenone blocks sodium reabsorption of the MR in the kidney, heart, and blood vessel tissues without affecting androgenic or glucocorticoid receptors. In non-epithelial cells, such as myeloid cells and macrophages, the mineralocorticoid receptor is likely activated by both cortisol and aldosterone. Persistent MR overactivation by aldosterone and cortisol leads to fibrosis, inflammation, and adverse remodeling in the heart, kidneys, and vasculature. Finerenone targets this fibrosis and inflammation by blocking overactivation of the MR in the kidneys and heart. After aldosterone binds the MR, it forms an MR-aldosterone complex via recruitment of transcription cofactors. Finerenone has bulky substituent groups that, when bound to the MR, leads to the formation of an unstable MR ligand complex, thus cannot recruit transcription cofactors. The recommended starting dosage is 10 mg or 20 mg orally once daily, based on estimated glomerular filtration rate and serum potassium thresholds. For the sake of time and simplicity of this medication review, I'm going to be silent on these next few slides if the viewer wishes to pause the video and learn more about dosing criteria and adjustments. To note, please refer to the package insert for additional information regarding this information listed. As important, I wanted to briefly discuss the differences between steroidal and non-steroidal MRAs. Focusing on the primary and secondary outcomes of the phase 3 trials, tissue distribution with Finerenone is equal between the kidney and the heart. As with the steroidal MRAs, it tends to shift more into the kidneys. Effects of blood pressure are not as significant with Finerenone, as it only reduces blood pressure by an average of 4 points. Although this may be beneficial in patients who are already at risk of hypotension. In the steroidal MRAs, we notice a larger impact of blood pressure reduction. Hyperkalemia risk and mean increase in serum potassium levels is less notable with Finerenone compared with steroidal MRAs. Although there is a continued risk for this adverse event, it is remarkably lower with Finerenone administration, regardless if paired with an ACE or ARB. To conclude the major differences between these two MRA classes, there is a greater cardiorenal benefit and overall decrease in all-cause death with the use of Finerenone. The Fidelio DKD and Figaro DKD trials demonstrated that a non-steroidal MRA can safely improve cardiac and kidney outcomes in patients. Future research with Finerenone is currently being trialed, as well as other considerations for its potential use. To name a few, there is ongoing evaluation of Finerenone in patients with preserved ejection fraction heart failure, chronic kidney disease without diabetes, and synergism with SGLT2 inhibitors, specifically empagliflozin. Other considerations are the evaluation of use in resistant hypertension and how potassium binders can potentially help alleviate increases of serum potassium levels that MRAs cause. Additionally, there are ongoing evaluations to determine the effectiveness and superiority between non-steroidal and steroidal MRAs. To conclude, I would like to thank my listeners for taking the time out of their day to listen to my medication review of Kerendia, also generically known as Finerenone. Please feel free to contact me with questions or further clarifications at either listed email below. To note, the next couple slides will have my citations listed, which were used throughout the presentation.